All right, I'm Matthew Pyle, and today we're going to be talking about FAST exam. These are today's objectives. So we're going to talk about the FAST exam and the e-FAST exam. We're going to talk about all of the many spaces where you can find fluid. We're also going to talk about pneumothorax, some of the limitations of this exam, and then we're going to look at some images. I have no disclosures, but I would like to say a very special thank you to Dr. Deering, who you will also be getting some lectures from this week. This PowerPoint, I would take no credit for any of the awesome animations. That's all her hard work. All right, so let's talk about the FAST exam. The FAST exam is the study you are almost certainly going to do most often in your residency and probably throughout your career. It's a good exam to learn first because the views are foundational views. They're going to be the same, very similar views to what you're going to see in your renal scan, in your echo, in your OBGYN and lung ultrasound lectures that you're going to get later this week. It's also historically one of the most important studies in terms of introducing the sort of paradigm shifting concept of bedside ultrasound. It's one of the first really important studies that showed how important ultrasound can be in making quick decisions and changing management. And so we sort of owe it from a historical point of view. So two things that point of care ultrasound people love are acronyms and mnemonic devices based on food for what things look like. So the FAST exam is one of our acronyms. It's one of those acronyms that was clearly thought of first, and then the words were found that fit into the acronym. So it stands for the Focused Assessment with Sonography for Trauma, which is just so clunky that it had to be done backwards. Now you'll hear people talking a lot about the e-FAST, which is the extended FAST exam, which is really just the FAST exam with lung views added in, and it's extended because that wasn't part of the original FAST exam, wasn't part of the original research that developed the FAST exam, but it's included in it now, especially for trauma patients. So I talked a little bit about how the FAST exam was historically significant, and we're going to talk very briefly now about its origins, and that's mostly so that you have a very clear understanding in your mind about how it fits into your practice. So these pictures are showing something that you've probably never seen and hopefully never will, and it's a diagnostic peritoneal lavage. And so to understand the FAST exam, you have to go way back to a time before CAT scans, before ultrasound, and you have to picture yourself in a trauma bay dealing with a hypotensive trauma patient. And you don't know if they're bleeding into their abdomen, you don't know if they have solid organ injuries, you don't know anything. All you can see is the skin. And so as a surgeon, your option is to go to the operating room and do an X-lap and see if there's blood, or wait and see if the patient improves without going to the OR. And so what was happening was that surgeons were going to the OR and opening the belly and not finding any injuries. And that was because the hypotension was from something else, the injuries were outside the abdomen, and so on and so forth. And surgeons never want to go to the operating room, cut someone open, and realize they didn't need to. So they came up with a test that was designed to show them if they should go into the abdomen without cutting the person open. That was to make a slightly smaller hole, instill a bunch of fluid into the abdomen, and then collect it and see how much blood was in it. And if there was a lot of blood or obvious gastric contents, then that suggested that there was an injury that they needed to go into the abdomen to repair. So the problems with DPL, as you would imagine, it's very invasive. And if anything, it's too sensitive. It picks up tiny amounts of blood, including the blood you might make yourself by making the small hole in their abdomen. It's a long procedure. It's not a quick thing, and you can't do it on pregnant women. So it was not a perfect test to answer this clinical question of does this person need to go to the OR. So then in the 80s, CTs became more popular, more widely available, and they seemed like they might be the better solution to this problem. They were non-invasive. You didn't have to make any extra holes. They proved themselves to be very sensitive and specific for free fluid and a bunch of other injuries in the abdomen that DPL couldn't pick up. The problem was, as a new technology, they were expensive, and they're still not exactly cheap. The other problem was they couldn't be done in the trauma bay. DPL could be done in the trauma bay. CT had to be done down the hall in the radiology suite, which is always a dark, cold, cramped, poorly staffed, poorly equipped room, and it's not a great place to take a sick patient. So this was not a perfect solution because now you were deciding if the patient was stable enough to go down the hall and sit in this dark room where you couldn't really tell how they were doing clinically. So we were still looking for a better solution. And so in the 90s, this is where point-of-care ultrasound suddenly bursts on the scene. And the ultrasound as a technology had existed, obviously, for years. We had been using it in OBGYN for years. And the advantages of ultrasound, obviously, it is also non-invasive, no additional holes. It is a quick test, much faster than a DPL. It's cheaper than a CT. It's also more accurate than a DPL. No chance of false positives from the extra hole that you're making. You can do it at bedside, which means you don't need to leave the trauma bay, and you could do it repeatedly. You could do it, and if it was negative, you could do it again in an hour and see if things had changed. And so, as a way of avoiding CAT scan or DPL, it had a number of advantages over those two tests. So the landmark papers that really showed how useful the FAST exam could be were inserting it into this algorithm. So a trauma patient who is unstable gets a FAST exam, and if it is positive, they go straight to the OR with no additional testing. And what was great about that was the FAST exam proved that there was blood in the belly, which meant that the X-lap that the surgeon was going to perform was necessary. There was blood in the belly. They were going to find a significant injury. And they didn't need the CAT scan to prove that there was blood in the belly, so you got to bypass the CAT scan and all of the risks associated with taking them down there, and you could make that decision immediately and at the bedside. Likewise, if the FAST exam was negative in an unstable patient, it meant that you could immediately start looking in other places. Is the hemodynamically significant amount of blood lost in the chest? Is it in the thighs? Is it on the floor at the scene? But you knew you didn't have to look in the belly. Now, stable trauma patients who get a FAST exam are a little bit of a different situation because the truth is stable trauma patients with either a positive or a negative FAST might end up getting a CAT scan. And it's not really going to change their management in the same way. You might see us do it, you will see us do it, on every trauma patient. And there's a few different reasons for that. It's not that we've forgotten its role in this algorithm. You do it at teaching hospitals because you want the educational opportunity. You do it at trauma centers because your trauma algorithm primary survey has to be rote. It has to be the same on every patient, because if you do a FAST exam on every patient, then you will never forget to do a FAST exam when you should do one. And if you're sort of picking and choosing when to do the FAST exam, sooner or later you will forget to do it on a patient who needs it. So that's one reason we do it on everybody. The other reason is that a stable patient with a negative FAST exam and really no other signs of abdominal trauma can be observed and never get the CAT scan. They may still get it as part of the PAN scan, and certainly if the FAST exam is positive and their vital signs are stable, they're going to get it. But you'll know ahead of time that there is at least free fluid in the belly and that CAT scan is likely to yield useful information. But the important point with the FAST exam, and the thing that's critical to remember, is this pathway here. The unstable patient with the positive FAST exam goes straight to the OR. So this is just an illustration of the sensitivities of those three tests. So DPL will pick up as little as 20 cc's of blood. That is too sensitive. That is going to find injuries that didn't need to be repaired, bleeding that was going to stop on its own, where the trauma of the X-lap is worse than the original injury. A CT will pick up as little as 100 cc's of blood. Ultrasound is very difficult to get a specific number for this, and part of that is that there just isn't a good way to do a study like this. A lot of the early studies involved slowly infusing fluid into a cadaver or a pig and having sonographers do repeat studies until they decided it was positive and seeing how much fluid that had taken. That's obviously not a very good scientific test. The other thing is that the numbers change all the time as machines get better and we get better at using them. You will see studies that quote positive FAST exams possible at as low as 50 cc's. That's obviously very good machines and well-trained people. You'll see other numbers as high as 500. But the bottom line is that it is at least as good as, if not better than, CT. So the original indications for the FAST exam obviously were trauma, blunt and penetrating trauma. But as we got more comfortable with the test, the scope widened to look for any kind of free fluid in the abdomen, so ascites, fluid from CHF, end-stage renal patients. Any of those patients can have free fluid in their abdomen, and the FAST exam is a good test for it. It also became the test to look for blood in the abdomen from non-traumatic things like ruptured ectopic pregnancies, ruptured aortic aneurysms. And then because of those things, it became a part of the evaluation of unexplained hypotension. So you're going to learn about the Rush exam at some point. It's one of the critical parts of that. So it really has a lot of applications now outside of the traumatic abdomen, but we still mostly talk about it in the context of trauma. So the FAST exam has limitations. Obviously, like any other ultrasound study, it is operator dependent. You need to be well trained, which you all will be. You also need to have done the scan, seen positives, seen negatives. You have to know what you're looking at. There is also, scientifically speaking, there must be some lower limit amount of fluid where the FAST wouldn't be able to see it, but the fluid is there, some small amount. Again, probably less than 100 cc's. Like any ultrasound study, it's limited by body habitus and bowel gas, and then with trauma patients, also air in the sub-Q will distort the views. And then the most important thing, especially when we're talking about trauma patients, is that it does not help you detect diaphragmatic injuries, hollow viscous injuries, and solid organ injuries. And that's important because we do it mostly on trauma patients. Those are potential traumatic injuries. Many of them require surgical repair, and the FAST exam won't help you detect the presence of those injuries. If those injuries have led to free fluid, sure. But otherwise, those things are going to require CAT scan. So that's where the CT for the hemodynamically stable patient with a negative FAST is still an important part of the workup. So how do you do the FAST exam? Well, the first thing is you have to pick a probe. These are deeper structures, so you're going to want a low frequency probe, so either the phased array or the curvilinear here, abdominal probes. The advantage of the phased array is it has a smaller footprint, so it's easier to fit between the ribs, but because it has a smaller footprint, you may need to slide it around to see all of the spaces, as opposed to the curvilinear has a much bigger footprint. You may see everything at once if you can line it up right, but either one is fine. So the FAST and eFAST, so the FAST has 4 views, the eFAST adds 2. So the traditional FAST exam is the right upper quadrant, left upper quadrant, subxiphoid and pelvis views, and then to make it an eFAST, you add 1 view of each lung. So your first view that we're going to talk about is the right upper quadrant. Now everybody always asks, which view do you start with? And the truth is, the FAST exam should be done so quickly that it probably doesn't matter which view you start on. There's a couple of clinical things to think about when you're deciding which view is going to be the most helpful. So the right upper quadrant view is the most likely place for fluid to accumulate in a patient who has been supine for a prolonged period of time, which a lot of our trauma patients have. But bear in mind that if you walk in off the street with a ruptured ectopic and the blood has had time to pool in your pelvis, then it's probably not the most sensitive view. The nice thing about the right upper quadrant view is that you are primarily looking through the liver, which, because it has no air in it, unless things have gone terribly wrong, it is an excellent acoustic window. So this is a relatively easy view to get. So how do you get the right upper quadrant view? We start here at their xiphoid process, draw an imaginary horizontal line to the anterior axillary line, put the probe there with the probe marker towards the patient's head, and this is the view that you will see. So their head is up here on the probe marker side of the image, their feet are down here. The other structures that you see are the liver, the kidney, Morrison's pouch between them, the lung above the diaphragm. Now, everyone always thinks of Morrison's pouch with the right upper quadrant and fluid accumulation. It's important to know that you're seeing other places where fluid will accumulate potentially. So because you're seeing above the diaphragm, trauma patients can have fluid above the diaphragm, as in hemothorax. Cirrhotics and the other people that we were looking for free fluid in the lung could also have pleural effusions, and so you would see those too. It's rare to have fluid between the liver and the diaphragm unless they are a cirrhotic with a sort of shrunken down liver, just because of the way the peritoneum usually anchors the liver to the diaphragm. So it's important that you see Morrison's pouch and the diaphragm and the space above the diaphragm. So that's one space and two spaces where fluid can accumulate, and we'll talk about the other two in a second. Again, this is the liver, the kidney, and the diaphragm. So the other two places where fluid can accumulate, now we've slid the probe down towards their feet. This is kidney here. This is the inferior pole of the kidney and the liver tip. And these are two other spaces. Because the Morrison's pouch is a three-dimensional physical space as opposed to just a straight line, and you have the pericolic gutter, all of which can hold fluid, it's very important that you also see the inferior tip of the liver and the inferior pole of the kidney, because those are the two other places where the fluid can accumulate, besides Morrison's pouch and above the diaphragm, which we already talked about. So again, here's kidney, here's the inferior tip of the kidney, inferior tip of the liver. And to get this view, we slid down towards the patient's feet, which are here. Their head is up here. So here's the right upper quadrant view again. Kidney, liver, diaphragm. Now, what are these white things here? From your physics lecture earlier, you learned that they are bright white. You can't see anything behind them. Suggests that they are something very hard and highly reflective, like bone. And you can see that there's a sort of repeating pattern of them. And we know that the probe, the head is up here, feet are down here. So if you haven't already said vertebrae repeatedly into your screen, these are vertebrae. Now what's interesting is you follow the vertebrae up, and I don't see any up here. Now you know that the vertebrae extend above the diaphragm, so why can't we see any more above the diaphragm? The reason for that is that normal healthy lung is mostly air, and the ultrasound signal gets scattered and can't hit the vertebrae that are here to bounce back to my probe and show me that there are still vertebrae. So this is a normal finding where the normal healthy lung has scattered the signal and I don't see the spine. As opposed to this person here, where you see vertebrae, 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 and they continue well past the diaphragm. So what's happening here, there's liver, there's diaphragm, and here are the vertebrae, and this is called spine sign. If you can see vertebrae above the diaphragm, that means that there's something in this space that isn't normal healthy lung, something with enough density that the signal travels through it, hits the spine, and bounces back. So in this person's case, you can tell that there's fluid here and just a tiny bit of lung flapping around. So this is probably a large pleural effusion. This will also happen with pneumonia or consolidations that increase the density of the lung, or hemothorax. Anything that isn't normal healthy lung will do it. All right, so here's the right upper quadrant view again. Kidney, and liver. What else are we seeing in this view? This tiny black crescent is free fluid. So free fluid will always find spaces between organs, and so it will be triangular or pointy or wedge-shaped like this. And so once you've looked at enough ultrasounds and you've seen this enough times, your eye should be immediately drawn to dark triangles, because dark triangles are always bad. Here's another dark triangle of death between the kidney and the liver. Here's another clip, illustrates the importance of scanning slowly. So here's the diaphragm, here's liver, kidney, and then another small crescent of free fluid. This clip illustrates the importance of the other two places where we see fluid accumulate. So we talked about fluid between the liver and the kidney. We talked about fluid above the diaphragm. So in this patient, you see a small amount of fluid here and a small amount of fluid between the liver and the kidney. But as they slide the probe down towards the feet, you see the inferior tip of the liver here, inferior pole of the kidney, and all this free fluid. Now we move on to the left upper quadrant view. Much harder than the right upper quadrant. The spleen is smaller than the liver, so you start off with less of a good acoustic window. The left kidney and the spleen are also more posterior and more superior, which means there's more likely to be ribs in the way. You're going to go in that same sort of imaginary line from the subxiphoid process, but now to more posterior axillary line. You may need to have the patient take a deep breath to bring the diaphragm down and bring everything below the ribs and into view. You may also need to turn the probe to fit it between the ribs. That's where the phased array is better than the curvilinear for this study. But it's just know that it's a little bit more tricky than the right upper quadrant. So how do we get this view? So you start subxiphoid and go now to the posterior axillary view. Probe marker still to the patient's head. So their head is up here, feet are down here, and this is the view that you were looking for. So you can see their spleen, their kidney, the space between the spleen and kidney, the diaphragm, and the vertebrae. So spleen, kidney, splenorenal recess, diaphragm, and vertebrae. Now, unlike the right upper quadrant, there is no attachment between the spleen and the diaphragm, so this space is very important to see because that is where fluid is most likely to accumulate. So that's one, and then of course you still see above the diaphragm, that's 2, between the spleen and the kidney, that's 3, and then the inferior tip of the kidney is 4. So here's that view again, spleen, diaphragm, splenorenal recess, kidney, and vertebrae. So here's the left upper quadrant. Is this positive or negative? This is like Dora the Explorer. If you said positive, you're right. So here is the spleen. Here's a small amount of black that you can see at the sort of inferior tip of the spleen here. You can see a little bit of black, again, thin crescent-shaped black between the spleen and the kidney. So that is a positive left upper quadrant view. There's a slightly more obvious one. Again, triangular, crescent-shaped black, which immediately catches your eye. This fluid is between the spleen and the diaphragm. Now we move on to the pelvic view. The pelvic view is the only view in the FAST where you would get the images in two orientations. And that's because there are more spaces for the fluid to accumulate. They are smaller spaces, they are oddly shaped, and so there's more opportunity for fluid to hide. We talk about men and women separately for this part of the FAST because the organs are different, so the spaces are different. Men have the rectovesicular pouch, and women have the rectouterine pouch, or the pouch of Douglas. Men also have the seminal vesicles and the prostate gland, which can sometimes look like free fluid. So we're going to talk about them separately first. So we'll talk about the male anatomy first because it's a little bit easier. So how do you obtain this view? So as you can see in this diagram, all of the spaces that you're interested in are behind the bony ridge of the pelvis, the pubic symphysis. Unfortunately, that makes for a terrible acoustic window. So since you can't see through the bone, what you're going to do is slide the probe down the abdomen until you feel it against the pubic symphysis. And then you should be able to see the bladder and rock or fan the probe over the bone and aim down into the pelvis. So usually start with the probe marker towards the patient's head, and then rotate the probe marker towards the patient's right. This diagram's a little confusing because it's actually you looking down on the image. So this is the probe marker towards the patient's right so that you can see the bladder and the near field and the seminal vesicles behind it. So here's that first view. It's the probe marker towards the patient's head. You see a large anechoic structure here. And this is an example of what fluid looks like when it's in an organ, right? No sharp pointy triangles like that free fluid. So this is fluid in an organ, so this is the bladder. And then in front of it here, you see the prostate and the seminal vesicles. And so the space where the fluid would accumulate is the rectovesicular pouch, so down here behind the bladder. Now with the probe marker turned towards the patient's right, you're getting that transverse view of the bladder. Now the seminal vesicles are in the far field behind it. What's important in this view is to know that this is an example of an artifact that you'll hear about again later this week called posterior acoustic enhancement. What that means is that all of the fluid in the bladder sort of amplifies the ultrasound signal of what's behind it. So you see how very bright it looks behind the bladder compared to off to the side here. Now that's helpful when what we want to see is behind the bladder, but it can cause problems when what we want to see is small and is potentially going to be washed out by all of this brightness. So you have to be aware of this artifact, and if you feel like it's too bright behind the bladder, you may have to turn the gain down because otherwise you may miss small amounts of fluid. So that's posterior acoustic enhancement. And that's something to be aware of in this view. Again, the space where the fluid would accumulate is behind the bladder right here. Okay, this clip's moving fast, but take a quick look at this. Okay, so here you can see anechoic, that's fluid, it's round, it's in an organ. You can see the walls of the bladder here. Probe marker is towards the head, so this is a longitudinal view of the bladder. And here is fluid in the rectovesicular space. Here's another similar clip, right? So here's round fluid in a bladder, probe marker towards the head, and here's the rectovesicular space, free fluid. Okay, so here we now are in transverse with the probe marker to the patient's right. You see a big fluid-filled bladder, and then all this free fluid behind it as they fan down. So it's that transverse view, fluid appears behind the bladder. Here it is in still. So here's the bladder, round, with the visible wall here, and this pointy wedge-shaped fluid behind it in the rectovesicular space. Move on now to the female anatomy. So the same basic principle, all the spaces that you want to see are behind the bony rim of the pelvis, the pubic symphysis. So you slide the probe down until it hits the pubic symphysis, and then you fan or rock down into the pelvis. With the uterus behind it, you now have the pouch of Douglas, or the space behind the uterus for fluid to accumulate. It's important to know that, like the liver tip and the inferior pole of the kidney, fluid can really accumulate anywhere here around the uterus, between the uterus and the bladder. There's extra spaces for fluid. Same thing, because it's a three-dimensional space, small spaces, and they're irregularly shaped, you want to visualize them in two planes. So here in longitudinal with the probe marker towards the patient's head, and then in transverse with the probe towards the patient's right. So here you have that longitudinal view with the probe marker up towards the patient's head. Large circular anechoic structure here is the bladder, and behind it the uterus, which goes all the way around like that, and then behind that the pouch of Douglas. So fluid would accumulate either here behind the uterus or between the uterus and the bladder. Here's what that would look like with some free fluid. So same longitudinal view. Here's the bladder anteriorly, the uterus behind it, and free fluid all around the uterus here. And then you turn the probe marker to the patient's right, and you get the transverse view. So now the bladder is near field or closer to the probe, and the uterus is behind it. So here you can see uterus, and off to the patient's right side here, they actually have a small ovarian cyst that comes in and out of view. Here's what that would look like with free fluid. So large bladder, behind it, tiny uterus floating in some free fluid. So here you can see that this free fluid is behind the uterus, so that would be in the pouch of Douglas. Now we move on to the last view of the traditional FAST exam. It's the subxiphoid view. It can be a challenging view in obese patients or pregnant patients, patients who have had abdominal trauma or are having significant abdominal pain. Later today, you're going to learn about conventional echo views, and one of them, specifically the parasternal long axis, can be used instead. It gives you the same basic anatomy and will also evaluate for effusion, and because it's looking through the chest, it's easier to do in those patients. If you are going to do the subxiphoid view, it's important to use as much of the liver as possible as an acoustic window, because otherwise you're mostly looking through the stomach, which is just a big bubble of air and will give you a very bad view. So how we obtain this view now with the probe marker still to the patient's right. As the name implies, you look up from under the xiphoid process, you put as much liver in the view as possible, and you see the bright white of the pericardium around the heart. Now, later today, when you're learning about echo, you'll learn about the ventricles of the heart and how to make interpretations about their function. But when we're doing the FAST exam, all we're really looking for is to see the entire pericardium, the bright white around the heart, and to evaluate for the presence of fluid. So here's a normal subxiphoid view. There's the liver, bright white of the pericardium, and no visible effusion. As opposed to this view, you see liver here, and black anechoic space between the bright white of the pericardium and the heart, and that's pericardial effusion. Here's another more striking example. So again, small amount of liver here, big fluid between the pericardium and the heart. What do we think of this image? Positive, negative. So you can probably see a small amount of fluid in this image here. But if you look, it looks like there's fluid there, and the pericardium is all the way down here. So what is this? It looks like it's outside the pericardium. So this is one of the possible false negative findings when you're doing the subxiphoid view. So that is clotted blood in the pericardium. And because the blood clots and gets more dense than fresh blood, it starts to have an echo texture that actually looks pretty similar to myocardium, and it may look like normal heart muscle with a small effusion, as opposed to what it actually is, which is a fairly large effusion that is just also clotted. I'll talk very briefly now about the two lung views that make the FAST exam into the E-FAST exam. So in the trauma patient, we are getting one view of each lung from the anterior chest, and we're looking for pneumothorax. You're going to have a dedicated lung ultrasound lecture later this week where you'll talk about other pathology, and you'll talk about pneumothorax in a little bit more detail. The idea with the E-FAST patient is that any significant pneumothorax will rise to the anterior chest wall in a supine patient. And so if you evaluate each lung anteriorly, you will be able to find significant pneumothorax at least as well as, but probably better than, you do with the portable chest x-ray that every trauma patient gets. So what are we looking at in lung ultrasound? Well, you can use the same curvilinear or phased array probe that you did the rest of the FAST exam with. You put it on the chest between two ribs with the probe marker towards the patient's head, and you will see the shadowing behind the rib, the bright white line that is the pleura, and then you will see sliding of that pleura back and forth as the patient takes a breath. An A line is a reverberation artifact of the pleura, so it's exactly as deep as 2 times the depth of the pleura, and it is a normal finding. It is a reassuring finding. It should not be there if there's pneumothorax. So here's that sliding. Here's the shadow of the rib. There's the bright white of pleura. And as the patient takes a breath, you can see the pleura sliding back and forth. It's negative for pneumothorax. If you're ever unsure, something you can do to improve the sensitivity of this scan is to use M mode on the pleura. So what M mode does is it displays a single strip of the image across time. So in this case, we've put the M mode cursor on some skin, some subcutaneous tissue, some muscle, pleura, and lung. So as the patient breathes, those first few things, the skin, the subcutaneous tissue, the muscle, they stay essentially the same over time. But everything below the pleura, which in this case is this bright white line here, it moves back and forth as the patient breathes, it scatters the ultrasound signal, and it appears disorganized like this. That means that what's below the pleura is moving, and that means it's lung, it's not pneumothorax. As opposed to this image, where the subcutaneous tissue, the muscle, the pleura, and everything below it are staying exactly the same over time, and that means there's nothing moving here because there's a pneumothorax. Pleura has peeled away, and this is empty space that doesn't move with respiration. This is called seashore sign. So this is as if these are waves at a beach. And this is barcode sign. Barcode sign means pneumothorax. Seashore sign means normal lung. All right, it's time to apply everything you've learned. Do a quick quiz. So we're going to show an image. You need to say what the view is and whether it's positive or negative for free fluid. All right, so here's kidney. This is spleen. So this is left upper quadrant view. And there's a small amount of fluid there. The way that you know that this is left upper quadrant and not right upper quadrant is that the spleen does not go down as far as the inferior pole of the kidney. All right, so this is right upper quadrant. Here's kidney and liver. And you can see some free fluid here. The other clue to distinguish the liver from the spleen is that you can see some blood vessels in the spleen here at the very start of the clip, and the spleen doesn't have any visible blood vessels. All right, so this is pelvis. Large fluid-filled bladder here. And behind it, a small amount of free fluid. So for bonus points, this is male or female. Don't really know, but certainly whoever this is doesn't have a uterus, so presumably this is male. And the probe marker is towards the patient's head or towards their right side. It's towards their right side, as you can see the bony rim of the pelvis here. So that's pubic symphysis, bladder, and that's the rectovesicular space here with some free fluid in it. And the quality of these images to represent real life scans. They're not always perfect. Okay, so this is left upper quadrant. Big kidney here. Little spleen up here. Is it positive or negative? It's negative. We had to show you a negative one eventually, right? They couldn't all be positive. There's no fluid here between the spleen and the kidney. No fluid at the inferior pole of the kidney. And no spine sign. The vertebrae stop here at the diaphragm. So it's a negative left upper quadrant. Okay, so this one's right upper quadrant. So here's diaphragm. Here's liver. Here's kidney. There's that tiny black crescent between the two that draws your eye. This is a positive right upper quadrant. Very faintly positive. Okay, so this is left upper quadrant. There's the spleen. And there's kidney. And you certainly saw some fluid here. The question is, where are you seeing this fluid? There's fluid above the spleen, and there's diaphragm. There's just a little bit of fluid that you can see above the diaphragm. This person has both intra-abdominal fluid and some fluid above the diaphragm in the lung. Last one. It's a big circular collection of fluid there. This is bladder. Probe marker towards the patient's right or towards their head. In this case, you can say that it's to their right because the bladder is round. sort of symmetrical in this view, so we must be looking at it in transverse. And then as they fan through it, seeing all of this fluid posteriorly, with loops of bowel floating in it. That is a positive pelvic view. All right. There's a lot of information. It's going to make a lot more sense when you start doing the hands-on session. If you have any questions, you can ask Kat now, or you can email me later.